We have seen much progress in several of the ICPD and MDG goals, as the previous speakers and Geeta has mentioned. But the progress in relation to maternal health, the MDG 5, has not been that great. And I'll be going into some of the reasons for that. Some of it has already been covered. Somehow, the MDG 5 indicators have been looked at only from the biological perspective. The factors that really create obstacles to the realization of rights have not been recognized, unfortunately. And I think unless we recognize that, the situation is going to be the same. ICPD talked a lot about primary health care. Somehow when it came to MDGs, I think we forgot the primary health care issues. And I think that's something that we need to be reminded on that. ICPD also talked about equity and quality of care, and that's something I think there is a lot of emphasis on that and recognition on that, which is good. I'm going to be looking at universal access, the progress, a reality check. And I'm going to be using some data to show you where we are. As the previous speakers have mentioned, in terms of policy, much progress. I remember immediately after the ICPD, maybe because of UNFPA, a lot of countries went on and developed SRH strategies. Of course, Philippines is still struggling with the RH law, but most of the countries have done that. And after 10 years, another revision has taken place. But nobody has really looked at what has happened to the initial, the strategy that was developed. The initial strategies did not have much on gender-based violence, but the subsequent ones did. Adolescent sexual and reproductive health was mentioned in all the strategies, but I don't think it has gone anywhere, as you've heard from the young people yesterday and also from the other speakers. Male involvement. There was a mention of a male involvement, maybe a sentence. I don't think we've progressed much on those issues. Well, we have progress in terms of fertility, but not all is well. Even in Asia region, we still have countries with fertility rates of more than 5, such as Timor-Leste and also Afghanistan. We also have countries with fertility rates above 3. Many of the countries still have fertility rates above 3. In the Pacific, there are many countries with fertility rates above 3. So we still need to do much more work to bring down the fertility. In terms of contraceptive prevalence rate, a lot of the countries have progressed a lot, but even now we see that a lot of the countries, the contraceptive prevalence rate is still less than 40%. There are some countries that have achieved a lot, like Indonesia, which has got a very high level of coverage. We also have Vietnam, which has a very high level of coverage, but also a high level of abortion. So what does that mean, contraceptive prevalence rate? We really need to look at that issue. In the Pacific Islands and PNG, somehow there has not been, the contraceptive prevalence rate has not really risen that high. Wanted fertility continues to be lower than the actual fertility. The other interesting thing is about unmet needs. There's a lot of emphasis on unmet needs. Unmet needs continue to be still above 15 and 20 in many of the countries, even in Asia, which has done comparatively better to the Pacific Island countries in terms of contraceptive prevalence rate. We still have 7 countries in the region that has unmet need for contraception above 20. I am rattling off these statistics because we think everything is well in terms of family planning and fertility, but it's not so. We have a lot of work to do. Everyone talked about significant reduction in maternal mortality. I think, yes, there has been some reduction, but if you look within countries and in between countries, the disparity is very high. This is one indicator where the disparity is, you can see maximum disparity. Asia and the Pacific has done well in terms of having achieved the MDG targets. Most of the countries are progressing, but recently we've had Philippines and Indonesia where there has been actually a great increase in maternal mortality. So it really raises some serious issues on the maternal mortality rates. And can we say that maternal mortality rate has really fallen? I think it is difficult to say that. In the Pacific area, most of the countries except the Pacific, Papua and New Guinea has lower maternal mortality. Now I'm going to show some slides. Could I have my first slide, please? I talked about there are major challenges with data. It's a pity that after 20 years, we still don't have good data on maternal mortality. As I mentioned, there are big differences between national figures mask the subnational inequities. And we have in this country, like the national figure may be low, but you look at the autonomous region of Mindanao, where the rate is almost double. There are disparities between the rich and the poor, and it's a shame that we don't have vital registration systems still missing in most of our countries. So data is a major issue. So when we are talking about monitoring, when we are talking about our achievements, I don't know how we can talk about that without good data. The next point is about skilled-birth attendance. There has been an increase, and if you look at the Southeast Asian countries, more than, many of the countries report a level of more than 70%, except Timor-Leste. But you look at Philippines, where the coverage is more than 70%, but the maternal mortality is also more than 200, the new data. Look at Indonesia, where the coverage is 83%, but the maternal mortality is high. So there is a disconnect here. And one of the major reasons for the disconnect is the definition of the skilled birth attendance. Even today, there is no agreement. There is no common definition. The reporting in countries is very, very different. Each country has its own definition for skilled birth attendance. So there is a problem with the data here because, that's why you see the discrepancy between high skilled birth attendance and maternal mortality. And I think that's something we really need to look into carefully. We talk a lot about maternal mortality. One issue that has been neglected, though ICPD talked a lot about, is maternal morbidity. While millions of women have survived the ordeal of death, the next slide please, the ordeal of death, many more in Asia suffer from disabilities. Obstetric fistula, it's a shame that obstetric fistula is a problem in countries, particularly in South Asia, but there is also evidence from Laos and Cambodia that more and more countries are reporting on obstetric fistula. If the maternal health services are good, there should be no obstetric fistula. Women suffer a lot, suffer shame, suffer discrimination. I think there's a lot that needs to be done in terms of maternal morbidity. Prolapse of the uterus, particularly in Nepal, a lot of women suffer from prolapse of the uterus. And again, their lives are miserable. But I don't think these things are caught, when you're talking about the indicators. Malnutrition continues to be a big issue. We talk about women not having adequate nutrition, and it leads to low birth weight, and also to intergenerational stunting. Stunting is a big issue that's being discussed worldwide. Anemia continues to be a problem. A lot of the maternal health programs talk about distribution of iron and folic acid. I've looked at demographic health surveys country after country. I don't think any country has achieved 100% coverage with that, which is a shame. And anemia, of course, affects productivity also. Next, I'm going to walk you through some of the statistics on the violation of rights. Geeta talked about briefly about the violation of rights. Even today, when we look at family planning services, I don't think the client's right to information, safe services, supplies, and follow-up are not really being met. These are rights of clients, and they are not being met at all. Provider bias is very, very evident in some of the programs, and I'll be showing you a slide on that next. The poor quality, and this slide shows that even when women talk about that they don't want to have any more children, you see that long-acting and permanent method use is so, the numbers are so small, which should be much higher. So this is really an indication of how the rights are being denied. It's easy to push the pill and the injectable, whether it is effective or not. So this is an indication of a denial of a right. The quality of counseling, everybody talks about counseling, but I think the quality of counseling is very poor, inadequate information is provided, and there are high discontinuation rates, as Geeta referred. And we have good evidence from a lot of the demographic health surveys that talk about it. We've also missed opportunities. When women undergo abortion in countries, or the ones that have been treated for abortion, I don't think anybody talks about family planning in the post-abortion period. We know that the fertility returns faster and many women conceive. This issue is forgotten. In olden days, when I was young, the family planning program used to focus a lot on postpartum family planning. I think that's forgotten completely, even though there are some, measures are being taken now to revitalize it. Choice of contraceptives is still limited. It's a pity that in India, even today, injectables are not part of the national program. So I think we really need to look at, there is much progress in contraceptive prevalence rate, yes, with shorter term methods, but I don't think women are getting what they want really. Stock out is a big issue. It takes a lot of courage for a woman to come to a health center and seek contraceptives, but when she goes there, she's turned away because there are no contraceptives. It's a pity that in spite of economic advancement, only 7 countries in this whole region buy their own contraceptives and take care of that. I was talking to the Honorable Deputy Minister of Myanmar. She was mentioning that they are investing much more. It's good to see that countries are investing much more in contraceptives, and that's something that I think each country should aim at. Male contraception and male involvement continues to be low. Vasectomy, coverage with vasectomy is less than 3% in most of the countries. It's even going down further. And of course, the unequal power decision-making and use of contraceptives affect the continuation of the use, and also the, affect the decision to make contraceptive use. Providers' attitudes are a big barrier. It's not just for family planning, as Geeta mentioned, it is also for other health services. And I think when we look at health services, the attitudes of the providers, we need to do something about it. And certainly I agree with Geeta, incentives are not the way to go about it. Next slide, please. Okay, now I'm going into getting into other areas of inequity. As you can see, unmet need for family planning, of course, is highest among the poor, as you can see here. Next slide. And a lot of the unintended pregnancies are among those with unmet needs. And of course, in most of the countries, since abortion is not legal, it ends up with unsafe abortions and death. Next slide. Now I want to talk about the 3 delays. I think we all know about the 3 delays in maternal health care. We've been talking about 3 delays for so many years. But even today, when we look at delay 1, which is access to information, very few women, yes, they know probably about danger signs, but very few women know about the right information about taking care during pregnancy, the danger signs, etc. Transportation, the delay 2 is reaching the facility. It still is a problem. Some of the interventions are covering that. And delay 3, which is really getting the right services in the clinics or in the hospitals, it's still a major issue. And wherever emergency obstetric care assessments have been done, it very clearly shows that this is a right that's being denied. So we have not really moved much in terms of the 3 delays, and it continues. The next slide, set of slides, next one please. We'll be talking about, I'm going to be looking at the inequity issues. As I mentioned, the skilled birth attendance coverage has gone up. So what? Inequity continues. As you can see, the red bars are all about the poor. They still don't have access. There is a big difference between the rich and the poor in terms of access to skilled care. The next slide, please. It has not improved over the years. Look at the deliveries by skilled birth attendants and cesarean section from 3 countries over a period of time. You can see the coverage has increased for the rich, but the poor are remaining where they have been always. There's no progress at all. So when we talk about progress, I think it's very important to look at some of the equity issues. Next slide, please. Again, we find inequity is the highest when it comes to care which is in the facility. You can see that the CPRs have gone up. Antenatal care has increased a little bit, but some of it is also given in peripheral facilities. But when it comes to really accessing care in a facility like a hospital, whether it's skilled birth attendants or cesarean section, the inequity is the greatest. So I think we really need to look at the continuum of care and also look at the inequities at various levels. Next slide, please. Okay, so what are the major challenges that's affecting lack of progress? One is the human resources. I mentioned about definitional issues. The numbers that are produced are inadequate, and even when they are produced, the distribution is inequitable. Much more, most of the providers are in the urban areas. And we still have non-supportive policy. This country, Philippines, has midwives, but they don't allow midwives to manage the active management of labor or to manage eclampsia, which is accepted worldwide. So you could have midwives and not have supportive policies. So there's a whole lot of issues related to human resources. Unless that's taken care of, I don't think we are going to progress much. Next slide, please. It's a shame that health spending by the government is still inadequate in Asia Pacific. We have Indonesia, Myanmar, where the health spending is very low. And as maternal health is the mirror of the health system, unless the health spending improves, I don't think maternal health is going to improve. So it's very, very important that we need to keep in mind that the health expenditures, the health spending by the governments is very low. Next slide, please. This is not a surprise to any of you. As you can see, the blue bars are the out-of-pocket expenditure. Out-of-pocket expenditure is very high in most of the countries in the region. It looks low in Indonesia, but I was told by an economist, most of the rich people may be going to Singapore, that's the reason. But in general, I think the out-of-pocket expenditures are very high. And we know that out-of-pocket expenditures really lead to catastrophic expenditures, and it really drives these poor people further into poverty. Many of the countries in the region have started demand-side financing and also results-based financing, and there are various types of financing. But what I find very interesting is it has not made any difference. It has increased the coverage. You see the statistics is very good. Antenatal coverage has gone up, maybe hospital deliveries have gone up, but I don't think it has made any difference to the out-of-pocket expenditures because the health infrastructure has not kept up to updated with the changes that have been made. There is a figure from India where it says that almost all the households from the poorest quintile paid more than 40% of their capacity to pay for health services. So, you can see how the lack of, access to good health services is going to add to the impoverishment of families. Now I'm going to move on to HIV, getting to zero new infections. I think there is a lot of good news. 26% reduction of new infections, with more than 50% reductions in India, Myanmar, Nepal, Papua New Guinea and Thailand. But we also have seen increase of new infections in Indonesia, Pakistan and Philippines among key affected populations. 35% of the people living with HIV are women. Please note that. And it has been remaining steady, but there is every chance it could increase. Migration is a significant factor in the epidemic. And it's also interesting that the new infections are among young people, as previous speakers have mentioned. Male clients of sex workers determine the spread and magnitude of epidemic in the region. Again, there goes for male responsibility. Unfortunately, though ICPD talked a lot about STIs, I don't think many of the countries have focused much on STIs. STIs have fallen between the cracks. I was happy to note that India and Myanmar had paid some attention to sexually transmitted infections. There's also been the HIV-SRH linkages. I think in the recent years there's been a lot of talk about HIV and sexual and reproductive linkages, but most of it is just limited to PMT-CT. I really don't think we've used opportunities in family planning clinics to talk about the preventive aspects and the linkages. Access of the key affected pop there, but when we really look at, and also, in the recent years there has been some positive laws that have enabled the key affected populations to access services. Next one, please. But one major concern in the region, and I'm sure Steve will be talking more about this, is men who have sex with men and the increasing trend. And this is a real concern, and this is going to be a big challenge. As we look at this group, next slide please, we see that even today 51% of the eligible population is getting treatment, and pregnant women, the coverage more than 50% in few countries, but the highest unmet need is in India. So we still have an issue with the rights of people living with HIV and their access to services. As I mentioned earlier, limited access to SRH services by key affected populations is another area, and there are punitive laws that hinder response. So I think these are some of the challenges that we have to keep in mind when we are talking about HIV. There's been a lot of talk about adolescents and young people. Next slide please. The unmet, next one. The unmet needs for family planning is highest in this age group. There's no surprise here. The next one please. Teenage fertility, this is a slide from the Pacific Islands, very, very high. Next one please. And we also know that the unmet needs and abortions among adolescents, young people are very high in Asia, as you can see in the slide. Child marriage continues to be a problem in the region. We still have higher than 50% in countries such as Bangladesh, Nepal, and also in certain states of India. So child marriage, even though it should not be there, it's a violation of the right of the child, it is continuing. Adolescent pregnancies, we've talked about. The next slide, please, is on abortion. It's a pity that abortion still continues to be to contribute to 14% of the maternal deaths. And even within countries where abortion is legal, such as India, Vietnam, women continue to die and suffer from complications as there are major health system barriers. And adolescents in particular are denied their right to abortion in these countries. And I was very happy to see that the high-level task force on ICPD Beyond 2014 recommended expanding access for all women and adolescent girls to timely and humane compassionate treatment for unsafe abortions. I think that is a great progress. Okay, now I'm going to be briefly touching on some of the ongoing challenges. Next slide, please. Next. I think Dr. Sadiq mentioned about the cervical cancer. Cervical cancer is a major issue here. But you look around at countries here. I think Thailand, Malaysia, and Sri Lanka have some screening programs. Cost-effective screening programs are available, but it's still not happening in most of the countries. And I don't even think it's recognized as an issue. Women suffer a lot unnecessarily because of this when there are cost-effective means of early recognition and treatment. Next slide, please. Physical and sexual violence. This is a slide from the Pacific, but it's a major issue. and it is becoming, intimate partner violence is what is becoming a major issue. And I find that, you know, the health system response is still not adequate. Women end up in health systems, you know, bruised or, you know, raped, but I don't think the health workers are still, their capacity is developed to really deal with the issue of gender-based violence. And that's another challenge, and I think that needs to be looked at. The humanitarian response and inclusion of sexual and reproductive health is not happening in many of the countries. UNFPA has promoted the MISP, which is the Minimum Initial Services Package. Philippines have done well during the recent typhoon, but most of the countries, it's not really implemented properly. It's not in the national preparedness plans. So there's much more that needs to be done with such frequent, humanitarian needs that's going on. Next slide. Sex ratio at birth is an issue in some of the countries, and I think that needs to be looked at very seriously. I know that it's not in all the countries in the region, but there are more and more countries where sex ratio at birth is becoming, adverse sex ratio is becoming an issue. Okay. We still have the future challenges of aging, urbanization, and migration. And one of the things is the migrants' rights. All the countries in the region benefit from the migrants and, you know, the income they send. But I don't think any of the countries have really fought for the rights of the migrants, especially women, who are the women and young people are the major proportion of migrants. But I don't think anything much is being done. But there are some good practices from Philippines and Indonesia where the NGOs have really supported the rights of the migrants. We talked about aging. I won't go into that much. But I just want to get into the last bit of my slides. Next one, please. Next. Okay. I'm sure most of you are aware of this. Certainly Geeta would know about this. The ICPD high-level task force policy recommendations, I think we should take note of that. It's nothing new, but it's really reinforcing what was talked about at ICPD, in Cairo. And I think we really need to look into this issue, and civil society has a responsibility to work more on this. The next slide is talking about some of the new developments, it's not really new, of the high-level panel on post-2015 MDG agenda. As you know, the proposed goal 4 is on ensure healthy lives. And one is happy to see that there is a mention of maternal mortality reduction and also ensuring universal access to sexual health and rights. But I feel that we have still missed out again on the sexual and reproductive SRHR of adolescents and young people. Have they been left out again? And the document says one of the transformation strategies is leaving no one out. But I keep wondering when I look at this document, where are the young people here? There are no special indicators for them except under employment. Again, gender-based violence is completely missing. It is mentioned under goal 2 or related to gender, but I think it needs to be reflected under the sexual and reproductive health because the health sector response is very, very critical in GBV. So I have some recommendations. These are really not recommendations. I think we need to continue, the civil society needs to continue working with governments to implement the policy recommendations of the task force on ICPD beyond 2014, continue to advocate for legislative reforms and effective implementation of rights-based approaches, particularly for adolescents on child marriage, abortions, people living with HIV, and implementation of the GBV laws. It's very important to create awareness about entitlements with regard to sexual and reproductive health. Ensure that the states are accountable for their obligations relating to sexual and reproductive health rights. And accountability should be built in as a core of these, to make states accountable for that. Monitoring the progress of the commitments is also very important. And I just put this slide up because most of the countries in this region made yet another commitment to the Secretary General on every woman and every child. But I really don't think, I think the commitments were made, more commitments were made at FP 2020. I don't think anything has happened, but I do think the civil society can play a role in making sure that the governments are accountable for the commitments they have made. Working with local parliamentarians is something which the civil society can easily do. And I was very happy to read about the open hearing of adolescent sexual and reproductive health in the Pacific. And I think more of such hearings need to be taken on, and with the help of the civil society, much more can be done. My last point is about universal health coverage. Everybody is excited about universal health coverage. Indonesia introduced universal health coverage on January 1, 2014. But was the country prepared? There are major questions about inadequate preparation, but jumping into universal health coverage without adequate health infrastructure. And I think that's something which, again, the civil society can play a role in cautioning the government and also in monitoring. Thank you, ladies and gentlemen. It's very clear that without realization of rights, we are not going to be progressing either with ICPD goals or MDG goals. Let us make a commitment not to let another day pass, violating more rights, without violating more rights. Thank you very much.